and accessible early childhood care and education system. We want to create a system that's as diverse as the racial and cultural identity of the young children and families in our state. We're committed to continue to learn and listen from families from a variety of lived experiences to inform policies and funding that will reduce disparities in health, education, and well-being. Now, we'd like to learn who's joined us today. Courtney is going to share a poll, and we would like for you to please provide your responses to the poll that you're seeing on your screen. With the first question, please select the sectors that you represent, and you may select more than one. We'll give everybody a minute to complete that. And you might need to scroll on your poll. The screen that I'm seeing doesn't have all the responses on there, so. And on the second question, why did you elect to attend today's webinar? Please provide us your responses for that. And Courtney, if you're able to see if we have most people have responded, if you'd like to share the results of that poll.
We have about 54%, so I'm gonna give it just a second before I share those results.
Okay.
Okay, it looks like we've come to a standstill, so I'm gonna go ahead and end the poll.
Oh, and I see a chat that it won't let you select more than one on the poll. So we apologize for that. We're still learning how to navigate some of this technology. So it looks like we have about 41% of the folks that indicated they represent a different sector than what we listed. But we do have, let's see, I'm trying to check. We have a fair representation from childcare, early childhood administration, but a nice cross sector representation from a lot of different sectors. So that's very exciting today. Most of the people attending the seminar said that this is relevant to their role. So we're happy to hear that. And quite a number of you then also are just interested in this topic, as I know that we all are. So thank you very much. Now it is my pleasure to introduce to you Justin Brown, who is Governor Stitt's Cabinet Secretary for Human Services and Early Childhood Initiatives. Secretary Brown duly serves in the role as the Director of the Department of Human Services, an agency that employs around 7,500 people statewide. And as you know, DHS is also responsible for child care services in Oklahoma. In his first year as director, Justin Brown has transformed the culture within DHS by establishing True North goals, prioritizing partnerships, and supporting innovation. As Cabinet Secretary, he serves to spread those values across the agencies represented in his cabinet. As a member of Secretary Brown's cabinet, OPSR benefits from his leadership and vision to improve the early childhood care and education system in our state. Secretary Brown also serves as a member of the Oklahoma Partnership for School Readiness Board. We have multiple opportunities to cross-collaborate when it comes to early childhood in our state. And now I'll turn it over to you, Secretary Brown.
Well, thank you, Deborah. Appreciate that. And welcome to everybody this morning, or this afternoon, excuse me, for the opportunity to get a sort of early release or first release of the report estimating the cost of quality early childhood care and education in Oklahoma. We've seen the report already, and our team had an initial viewing of it or presentation of it, and the quality is very high, and excited about the opportunity for everybody to see it. Ultimately, as an organization, we intend to use this work alongside lots of other work to inform the sort of transformation or our participation in the transformation of early childhood in the state of Oklahoma. Our kids deserve a system that serves them, and our providers deserve a system that promotes the highest quality in early childhood. So I wanted to just really briefly share with the group a process that we went through early on, and Deborah indicated or gave a little bit of insight into that process a second ago, but it was called Finding Our True North. As an agency, we created agency-wide True North goals, really 8 of those, and all these are online at ourokdhs.org. But these goals are around a handful of different objectives, some around the science of hope and understanding adverse childhood experiences and childhood trauma. Some are around just being an innovative organization. To Deborah's point with OPSR's priority around equity, we have a similar True North goal. We're doing a lot of deep work around equity. In fact, I have to leave this meeting after my comments here to move over to a conversation with a small group of our employees to discuss areas in which we are recognizing systemic bias within our own systems. So it's really impactful work that we're doing around equity, diversity, and inclusion, and proud to be a part of that for our state. So anyway, so we went through this big process called Finding Our True North, where the agency itself identified, or we identified for the agency, large goals that we were going to pursue around some of these topics. We also spent time within our divisions and did really deep work, even deeper than that executive leadership True North work. Each division identified 3 to 5 of their own True North goals, really areas in which that division itself would drive value for the people that they serve. And Child Care Services identified 3 of those, and I wanted to share with you what one of those True North goals is for Child Care Services. It's relevant to this conversation around quality. I think you'll see why. And again, all of this is online at ourokdhs.org. But the first Child Care Services True North goal is improving the quality of and access to child care programs in the state. Of course, this report, and what you will see, helps to inform that work. You have to start with a foundational understanding of what the cost of that quality would be in an ideal system. So we appreciate the partnership with OPSR, with the RAND Corporation, who did tons of deep work here in developing this report for us and for all of you on the call. Really, again, to inform the work about improving the quality of and access to childcare in the state of Oklahoma. These strategies that will come as a result of this work and other areas of work are evolving always. This is not an opportunity where you take a look and you build a work group and then you do something and you stop and you mark it good. This work will never be done. We can always improve quality. We can be informed by what new research shows us, physical research, mental health research, educational and developmental research. And so we're excited about the opportunity to really work together with our partners in the community and our partners like OPSR, who've been instrumental in helping to inform the work that we're doing. So I just wanted to end by saying thank you for the opportunity to say hello. Thank you again to OPSR and to the RAND Corporation for your work here. I also want to thank our team, some of whom are on the call, who really do immensely deep work on childcare and early childhood and really pursuing the desire for improved access and quality. So thank you for the time and the opportunity to address you all. Appreciate the hard work here. And with that, I'll send it back to you. Thank you, Deborah.
Thank you, Secretary Brown. It has been such a pleasure to work with you. I often say that you meet very few people that has such a big heart for this work as what you do, Secretary Brown. And so we appreciate working with you and look forward to continuing to work on this and many other areas around early childhood. So thank you again for being here. If, as Secretary Brown says, he does need to leave. If you have specific questions as we go through the presentation that perhaps we're not able to answer, and we will follow up with DHS and Secretary Brown and post any of that feedback if that's helpful after the presentation. So as we talked about the transformation within DHS, the past 18 months have been transformational for early childhood in Oklahoma. The award of the Preschool Development Grant provided our state with the funding, finally, to better understand the status of early childhood care and education services, the gaps in our state, and the needs of family and community members to support child well-being. Oklahoma's stakeholders were interested in gaining a better understanding of the cost of quality care to inform funding decisions, set priorities for quality standards, and align quality across all early care and education settings to create more equitable outcomes. As you know, the preschool development planning grant process was fast, and fast doesn't often attract researchers. However, the RAND researchers accepted the challenge and produced a very high quality report in Oklahoma in an unreasonably short amount of time. As with any great research, as we peel the layers of the onion back, more questions often arise, and we see this as a very helpful journey in our process to better understand the cost of quality care in the state. This report should be viewed as an important first step to guide those quality standards that are attainable, adequately funded, and that support children regardless of where they live or where they receive services. This study was also conducted in a time that we are all struggling to remember, and that's pre-COVID-19. Fortunately, there's valuable information in this report that will inform our future decisions in this ever-changing landscape of early childhood care and education services. Oklahoma leveraged funding from the OK Futures Preschool Development Grant Birth to 5 Year 1 Planning Grant for this study. The study was conducted by Dr. Lynn A, Senior Economist, and Stephanie Walsh, Policy Analyst, both with the RAND Corporation, which is an internationally renowned nonprofit research organization focused on solving public policy and challenges. Dr. Karoly and her RAND colleagues have conducted studies of the cost and financing of early childhood care and education in other states, including California, Minnesota, New Hampshire, South Carolina, and Virginia, as well as for local communities such as Cincinnati, Ohio, Santa Monica, California, St. Paul, Minnesota. So you can see that the prior experience that they brought to the table was certainly valuable to our work in Oklahoma and was key in us selecting them to lead this study for us. Karoly was also a member of the National Academies of Sciences, Engineering, and Medicine Consensus Panel that produced Transforming the Financing of Early Care and Education in 2018. Many of you are familiar with that report. This report contains information that continues to inform policies for financing a sustainable early childhood care and education system. Throughout this presentation, please add questions to the chat box. Your microphones are muted and questions will be moderated by Stephanie Walsh. Again, we're recording today's session and the recording will be available on the OPSR website following the presentation. Lynn, I'm going to turn it over to you and we look forward to your presentation.
Great, thank you, Deborah, and I'm really pleased to be here today to talk about this work. I will also mention, and I have a slide at the end, that the report is available online on RAND's website, and I'll provide the URL. It's currently in a pre-release format with the final report forthcoming, so that information will be on a concluding slide. But before I get started, I also wanted to thank you, Deborah, and your team for the support you provided on this project, including direct support, as I'll mention as we get going. Part of our work involves collecting information on expenditures on the part of centers and family child care homes throughout Oklahoma, and we really appreciated the support from the OPSR team and some of that outreach and recruitment. I also want to acknowledge the providers that agreed to participate in this study and the time that they gave to provide us the information that we were requesting. They are all anonymous in our report, but I hope some of them may be listening in today. Let's go to the next slide. So as a starting point, why would Oklahoma be interested in a study looking at the cost of early care and education? And I think it's important to set this in the context of the Preschool Development Grant, Birth to 5 for Oklahoma, which in looking forward to building a better system of ECCE and the broader Birth to 5 services, it's important to understand the cost of the programs and services that are delivered as part of that system. In the case of ECCE, typically the information we have is from market rate surveys, which really tells us about the prices that providers charge for their services, such as how much it would cost on a weekly basis for a family to have their child enrolled in a program, whether they're an infant or a toddler or preschool age, and for a certain number of hours per week. So that information is routinely collected as part of setting reimbursement rates for the child care subsidy system. But those prices do not necessarily reflect the true costs that providers face in delivering care to the children that are enrolled in their families. And so we ideally would like to know more about what those costs are and how costs vary with quality features. And in the case of Oklahoma, we're doing that in the context of the quality rating and improvement system reaching for the stars. Ultimately, the kinds of information that we are going to be talking about in this study can help inform the reimbursement rates under the child care subsidy system, and more generally help the state understand as programs are expanded, efforts to improve quality are in place, what the resource requirements are going to be to do so. And as we've mentioned, I think this is a fitting component of the Birth Through 5 PDG grant in really providing important information relevant for cost and financing. Go ahead to the next slide. So I want to emphasize the two key questions that motivated our work. First was to understand the per child cost of ECCE in the state separately by child age, infants, toddlers, and preschool age children. And I want to emphasize that this is an estimated per child cost. And I'll talk in a moment about some of the limitations of doing this kind of work in terms of how we can draw, excuse me, how we can draw inferences about true costs. We also want to understand what are the fundamental factors that drive ECCE costs, which of the myriad number of factors that might be embedded in our quality rating and improvement systems or licensing standards that have a significant effect on the costs that providers face. And that could be everything from the size of the provider, what we would call the scale, the ages of the children served, the quality level that a program may attain, the geographic region, and other key structural parameters that are typically associated with quality and often embedded in licensing and quality rating standards, such as teacher-child ratios, teacher qualifications, and compensation. So the next slide. What I'd like to do in the presentation today is to spend a little bit of time telling you about the approach and methods that we use, just so you have that context for the results, which we'll discuss next, and then we'll conclude with some of the implications of our work and the recommendations that we identified. So on to the next slide. Let me start then talking a little bit about the approach. So we took what we call two-pronged strategy in both collecting data directly from providers about their costs and incorporating that information into a cost model and then analyses based upon the data and the cost model. In the context of the data collection, we collected information about the program structure and expenditures for 25 different ECCE providers in Oklahoma, varying by setting type, geography, and quality rating tier. I'll say a little bit more about that distribution of providers. And we estimate from the information that we obtain the cost per child, again, separately by the setting type, the child age group, and quality tier. And we examined how other factors vary across providers in terms of their cost structure and their ultimate cost per class. That information helps us understand the features of programs in Oklahoma and aspects of program structure and cost elements, and those we incorporated into a cost model. Essentially what the cost model does is it establishes a set of assumptions about how a given provider would be structured, such as the number of classrooms in the case of centers by child age group, what would be the requirements around ratios and group sizes, what would we assume for teacher education levels and compensation, and a variety of other costs associated with everything from the space that the provider uses to the meals that they provide and the education and learning materials. So we establish with those assumptions a set of baseline assumptions that lead us to an estimate of the cost per child across these different situations or scenarios that we've established. And we could perform sensitivity analyses to say, for example, if a provider has a desired enrollment, what if they are under-enrolled and don't have as many children as they intend to serve? How might provider size or the scale of the provider affect costs? And what about differences in the cost of living in a given area? So we can establish both those baseline results and sensitivity analyses. And it's important to note that this cost model is not necessarily trying to directly replicate the costs that we saw from the providers themselves. In fact, that cost model really is, in a way, illustrative of a provider with a particular structure and what their costs would be and how costs would vary. The data collected from providers tells us something more about the real world, although because we have a very small sample of providers, it's not information that we can use to draw broad conclusions about providers throughout Oklahoma that might generalize to what we would see with a larger sample that would be more representative of the state. Finally, in terms of our analyses, based on both the observed data and the cost model, as I said, we estimate cost per child. We can compare the data that we observed with the model-based estimates. We can compare the costs based upon both the directly observed providers and the model-based with the child care subsidy program reimbursement rates to try to understand whether or not those reimbursement rates would be sufficient to cover provider costs. So that's ultimately the way in which we use the combination of cost data from real-world providers and the cost model. Go ahead to the next slide. So just to say a little bit about the data collection, in our provider sample, the 25 providers that we collected data from, includes licensed centers and licensed large family child care homes and the smaller family child care homes. So all of these are licensed providers. We did exclude from our sample Head Start programs, tribal providers, and the state-funded state school-based preschool system in Oklahoma, as well as license exempt family friend and neighbor care. And in part, this allowed us to focus in on the set of providers that were most relevant for the child care subsidy part of the system and providers that we could readily include in data collection. So it's important to keep in mind that we're not representing all providers throughout the state, although this is a very substantial group of the licensed providers in the system. Go ahead to the next chart. So from those providers that we interviewed and collected data from, we asked about program information to understand the basic structure of the program. That included their quality rating and any accreditation, the number of classrooms that they have and the children enrolled in those classrooms by age group, the desired and actual enrollment by classroom, program and classroom staffing, benefits provided to the staff in addition to their salaries, sources of revenue, and then detailed expenditures for the most recent fiscal year. And one more addition to the slide is to note now on the right, of the 25 providers we collected, 13 were centers, 6 were large family childcare homes, and the other 6 were the smaller family childcare homes. And you can see that there's some variation across the star levels in the rating system, 1 star and 1 star plus. We've grouped together in that first row, 2 star and 3 star providers. In part, this distribution reflects where providers are overall in the rating system. So there are relatively fewer, for example, among the family childcare homes, fewer programs that have attained a 3-star rating. So we do not have as many of those within the sample. Go ahead to the next slide. So in terms of the cost model, I want to say a few words about how we undertook that part of our work. We started with a set of baseline assumptions, and I'll say a little bit more about that in a moment in terms of provider type, and we differentiated primarily between centers, licensed family childcare homes of the 2 sizes, the age groups of the children served, where we were going by the age groups recognized in licensing and the QRS, and the quality rating tiers, the 4 tiers in reaching for the stars. We also built in assumptions that address the staffing model, and by that I mean, for example, assuming a center of a certain size would have a director, what size would be required before there might be an associate director, and other staff at the administrative level, as well as the staffing in each classroom with following, for example, ratio and teacher-staff requirements, teacher-child ratio requirements, so that we could capture both the direct costs for each classroom in the model-based assumptions, as well as program-level costs. We also assumed that providers could be represented at each of the 4 tiers in reaching for the stars. And we made some assumptions about the resources that would be used as providers moved up those rating tiers. And going to the next slide, you could see what some of those assumptions look like. So across the row are a number of features of programs that we assumed would vary either at each step of the rating system or in some cases in moving from one tier to another. So for example, in meeting a maximum teacher-child ratio, we used the licensing standards for 1 star, 1 star plus, and 2-star providers. But by 3-star, we assumed that those maximum ratios were lower. And so group sizes would be smaller, fewer children per teacher. And we based our assumptions on the accreditation standards, since at the 3-star level, providers would be accredited. So we used, in this case, NAEYC standards for centers and NAFCC standards for family childcare homes. Likewise, as we moved across these tiers, we assumed that the minimum teacher education would be the same at both 1 star and 1 star plus, but by 2-star and 3-star, that those education requirements would be increasing, in part aligned with the specific standards in the QRS, as well as the standards that come with accreditation. And you could see across this grid here that in many cases, as you move across the rating tiers, more resources would be required, for example, in the form of professional development, the accreditation costs for reaching that 3-star level, increased resources to support a higher quality learning environment, more family engagement, and program evaluation. So in essence, we built into the modeling effort assumptions about more resource use as quality increases, which naturally means that we're going to see a higher cost per child as we move up the rating tiers based upon our model estimates. So go ahead to the next chart. So continuing on, a few more aspects of the cost modeling approach. So as I said, we had baseline assumptions. Then we undertook sensitivity analyses to see how per child costs would vary with different scenarios, such as a scenario where providers were under-enrolled, where their program size might be higher, or they would be in geographic areas with different costs of living, both lower and higher. And we could compare those estimates against our baseline. This is something that would be harder to do in the context of actual providers because we don't necessarily see all of this variation unless we had a very large sample. And then lastly, we also compare the per child cost estimates with the child care subsidy program reimbursement rates that would apply under the different quality rating levels, whether providers or centers, family child care homes, and so on. So go ahead to the next chart. So I want to say a few words about limitations that I think are important to keep in mind. And as Deborah noted, this was a study that was conducted in a relatively small amount of time with pretty modest resources. So in part that dictated some of our study design aspects and tie into some of the limitations. So in many respects, we view this as a first step toward using this kind of information as part of understanding the costs of ECCE in Oklahoma. So with respect to the cost data collection, again, I just want to emphasize that we do not account for all provider settings where children in these years from birth to kindergarten entry may be enrolled in programs. The data from the providers really should be viewed as illustrative rather than representative. In fact, our design and sampling providers was to try to maximize the variation we would see to make sure that we had providers across different rating levels in different types of settings in different geographic areas of the state. Another thing I think it's important to recognize is as I report on estimates of costs, like I said, these are estimates and they're based upon records that providers have of their expenditures during a given fiscal year or accounting year. And some providers were in a better position to provide more accurate records of their expenditures compared to others. And in part, that was a function of whether or not they had the resources, for example, to support somebody to help with their keeping track of their financial records, an accountant, bookkeeper, or whether that was something that they were doing on their own. So I think it's important to recognize that there's probably some variation in the accuracy of the information that we have, which could account for some of the differences that we see. With respect to the cost model, again, I want to just emphasize that all of our analyses are based upon certain model assumptions, and partly in looking at key cost drivers, we can understand that those are factors, those are assumptions that matter more than some of the assumptions that might have smaller implications. In other words, a change in a particular assumption may not lead to much difference in our bottom line estimates. But again, those sensitivity analyses help us understand which assumptions matter most. So let's go ahead into the section where we're going to start to talk about the results. And I'm going to go ahead on to the next slide with findings specific to what we learned from the provider data. So again, this is for 25 providers throughout Oklahoma, representing both a small number of centers and family child care homes. And I think the first thing to emphasize, in part because of our design in capturing different types of providers in different parts of the state, is that there is tremendous variation in both the program operations, and we'll see this also subsequently in program costs. So on to the next slide to illustrate this. And there are many features of the providers and their program structures that we capture. So I'm just using this as a way to illustrate some of the differences. So this chart shows you across the rows different supplemental services that providers may offer as part of their program, such as weighing and measuring the height of the children in their program on a regular basis, like once a year, whether they would have vision and hearing and dental screening, or for speech, whether there are specific speech services operated, developmental assessments conducted, and so on. And you can see that, again, with 13 centers and 12 family child care homes, that the row for meals is one that all providers are doing consistent with licensing and other standards. But if you look at other examples, none of the providers we talked to, for example, undertook dental screenings or provided speech services. And there's some variations on things, whether or not the provider provided referrals to families to other services. That was true for 9 of the 13 centers and 6 of the 12 family child care homes. The similar number provided transportation, but that was relatively rare compared to the set of 25 providers. Just 6 provided those services. And you can see that centers tended to be more likely to provide some of these services than the family child care homes, which might be expected, again, just because of differences in resources and program scale that might support those kinds of services. On to the next chart. Another common feature that we saw, and this is well known and documented in other sources, is relatively low compensation. And by that, I mean both the salaries that were paid as well as the benefits. In some providers, we actually got specific salaries at the position level. And many, we did not have that level of detail, but relatively low cash salaries was definitely a pattern that we saw. But just to illustrate what we saw on the benefits side, the next chart has a similar layout to the one I just showed you, with centers in the first column and family child care homes in the second. Again, the same 13 and 12 providers in each group. And the rows represent different benefits that are offered to full-time staff. And they include resources such as being paid to attend staff meetings or to participate in professional development. These are typically expectations of the job that an individual would be expected to do and be compensated for. As you move down the chart, we get to some other types of benefits, such as whether or not there's sick pay, vacation pay, and then finally a set of benefits around retirement savings, health insurance, dental insurance. And you can see that the counts generally decline as we go from those types of supports that have to do with participating in staff meetings, professional development that are typically considered part of the job, all the way down to those that are additional benefits that only a subset of providers provide, such as the health and health benefits and retirement savings. And so you can see, again, that center-based settings are somewhat more likely when they provide these benefits to do so, although rates are not too dissimilar when we look at things like vacation pay and sick pay. But it's not the case that some of these additional factors like sick pay, vacation pay are universal across the 25 providers that we talked to. Go ahead to the next chart. Another source of variation that we saw was the types of revenue that providers rely on. And again, I'll bring up a comparison chart like I just showed you. This is now revenue sources where the light green rows represent public sources, such as Oklahoma Child Care Subsidy Program in the first row, Tribal Child Care Subsidy Program in the second row, and the USDA Child and Adult Care Food Program, CHCFP, in the third row. Those are the major sources of public subsidies that providers may access. And then the darker green rows are those that you could consider to be private sources, such as parent-paid tuition and fees, and then contributions that providers may receive from, say, a sponsoring agency, like if they were part of a church or another organization, other local community groups that may provide contributions or subsidize certain types of services, contributions from parents' employers on the list, also special events and fundraising efforts, and private donations. So you can see here that among the centers, all 13 were participating in the Child Care Subsidy Program, but just 7 of the 12 family child care homes did so. Likewise, the Tribal Subsidy Program was more common for the centers. We wouldn't necessarily expect that that would be universal, given that we had providers that were in parts of the state where there wouldn't necessarily be tribal providers or subsidies to take advantage of. And then the USDA subsidy program was also not universal, 8 of 13 centers and 10 of the 12 family child care homes. And as you look across the private sources, of course, parent-paid tuition or fees was a universal revenue source across our providers, but much less common, especially among family child care homes, to have these other sources of contributions at all, and certainly in the family child care home settings. Let's do the next slide, please. Another aspect of variation, and this is something I alluded to earlier in one of the limitations, was that we saw quite a bit of variation across providers in the extent to which they had well-organized and well-documented financial records. And again, this is in part a resource issue in terms of having the ability to keep these kinds of records and the ability to possibly provide for an in-house staff person or to contract out these kinds of accounting services. But this is important because I think those providers that don't have the resources to keep good financial records are potentially handicapped in terms of being able to understand and track their expenditures against, for example, a budget, to know how to plan for the future in terms of expected expenditures and revenues. And that has implications, I think, for the financial stability of providers and their ability to be an ongoing business and to have that kind of financial information inform their planning. So go ahead on to the next chart. So now I'd like to turn to some of the findings from the provider cost data. So we've just been talking about some of the features of the providers. Now in terms of cost, we begin by noting that our estimates of the per child costs for the sampled providers varied widely. So in part, this might be expected because we saw very different program structures. But this is true within the same provider type, so within both centers and family child care homes, and within the same reaching for the STARS rating tier. So even accounting for providers that were all at the same rating tier, like a 2-star, we saw pretty big differences in the costs of providing ECCE across child age groups. And let's illustrate that in the next chart. That I'm going to summarize the cost per child. I'm doing so here on a weekly basis. So this is in 2018 dollars, the estimated weekly per child cost. You could see centers are shown first in a set of rows looking at costs specific to different age groups. And then for family child care homes, we have the two sizes of family child care homes. But for family child care homes, we did not try to estimate a cost by child age because of the mixed age groups. So you'll see that these are average costs across the ages of children served in any given provider. And what I'm showing you in the first column is the minimum estimate across our providers, and then the second is the maximum. So this is a minimum to maximum, or a range of the weekly per child cost. And in the far column, you can see the number of providers that were used to generate these estimates. And as you look across these rows, now again, this is holding constant the child age and the different settings, centers versus family child care homes. But within any given row, we see differences that are as much as 2 times. So for example, for centers, children 12 to 23 months, we had an estimate as low as $106 per week and an estimate as high as $218 per week across the 13 providers. So you can see essentially a difference of a factor of 2. And similar variation, and sometimes even larger factors of variation in these other rows. Go ahead to the next chart. A second finding to point to is that within the family child care homes, one of the sources of variation that was an important determinant of overall cost was the extent to which providers varied in the reported compensation for the owner and the operator of the small business, and the extent to which their housing costs were deducted as a business expense. And again, just to illustrate what that looked like among the 12 family child care homes, the next chart shows you 4 different indicators across the rows, and the columns show what that indicator looked like for family child care homes at a minimum and the large family child care homes at a maximum, the first 2 columns, and then for the smaller family child care homes, the range from the minimum to the maximum. So as an example, the reported owner salary or profit in aggregate on an annual basis, 0 is reported by one large family child care home, and close to $34,000 at the upper end in a large family child care home. And you can see that the range is even somewhat similar in terms of absolute value, but the minimum is about $11,000 up to a maximum of almost $50,000. Likewise, when you compare across the percentage of housing that was assigned as a cost to the business, that ranged from 10 to 100% among large family child care homes, 21 to 60% among the smaller homes. And you can see what that combined effect is of the housing costs and the provider, the owner-operator salary is a quite large range, again, on the overall, if you will, return to the provider from operating that small business. And again, this is a small number of cases, so these are just meant to be illustrative, but even with these small number of providers, we see this pretty big range in the way in which the finances are handled and what that means for the owner-operator of the business in terms of their compensation. Go ahead to the next chart. So another finding here to highlight with respect to the provider-based cost data is that we see that when we map onto the estimated cost, the subsidy reimbursement rate that a provider would receive based upon the child age and their quality rating tier, we see also tremendous variation in the percentage of that provider's costs that would be covered by that reimbursement rate. So providers that were at the high cost end of the range were ones that would, based upon that subsidy reimbursement rate, would be under reimbursed if that were the only source of reimbursement that they received. And on the lower cost end, the subsidy amount would be more than cover their costs. And a pattern that we saw more generally was that rooms in centers where infants were served were less likely to be fully reimbursed. In other words, because infant costs on a per child basis are higher than the costs for older children, largely driven by the ratios, we see that they were less likely to have their full cost if the subsidy reimbursement were the only source of reimbursement that they received. So let's go on to the next slide. So now we're going to transition to talk about findings from the cost model. And again, this model-based effort is one not necessarily to replicate what we saw among providers. It was certainly informed by the information that we gathered by providers, but also based on other similar cost modeling efforts. But this cost model provides an opportunity to understand key cost drivers by varying our assumptions, as well as estimates of the potential level of cost as providers move up the quality tiers. So one of the key findings from the cost model is that the teacher-child ratio is a key cost driver. Providers in centers in particular, where we're looking at these ratios, as children age from infants to preschoolers, we see that the per child cost declines as a result of allowing for an increased number of children to be with each teacher or assistant teacher in a classroom, and effectively to have larger group size. And let me just illustrate that in the next chart. So what we have here is a bar chart showing now, we've switched to reporting costs on an annual basis, but these are per child costs, again, in 2018 dollars. This is specific to a two-star provider, so we have assumptions about those two-star providers. Licensing ratios are used in this case, and you can see for each age group, the bars on the left is the age group label, but also the ratio that we're assuming. So here, for infants 0 to 11 months, the assumed ratio is a 1 to 4, one teacher for every 4 children, and as you move up to the age 4 group, it's a 1 to 15 ratio. And so you can see as a consequence of those changing ratios, we go from an estimate of over $12,000 cost per child on an annual basis at a two-star level down to about $5,300 per child in the older age group here, the age 4 age group. And that's effectively because we're holding everything else constant in our model. This is entirely due to that change in a ratio from 1 to 4 to 1 to 15. Now, we don't always see this same striking difference in the prices that providers charge, and in part because some providers try to even out that cost for families so that you don't have that very high cost for an infant, and effectively families pay a little bit more than the provider's true cost for the older age children and somewhat less than the provider's true cost for the younger children. So it's important to keep in mind that these are cost estimates rather than the prices that providers might charge in the actual marketplace. Go ahead to the next chart. So with our assumptions about higher resource use for higher quality ratings, the per child costs do increase with quality. And so think back to that chart where I showed you that across the quality rating tiers, we have changes in the ratios and group sizes, particularly by getting to tier 3 with the accreditation-based standards. And along the way, also our assumptions about increased costs associated with the learning environment, with family engagement, and so on and so forth. So let's see what that looks like in terms of our estimates. So this is the same kind of chart that I just showed you, but now we have purple bars for 3-star providers and blue bars for 2-stars. So the numbers I just showed you are the same in the blue bars, the $12,300 so on dollars for an infant on down to $5,300 for an age 4-year-old. But now, because of the higher quality standards at 3-star, the purple bars extend to a larger number. And you can see on the labels again for the age groups in each of these bars, we're showing first the ratio for the 2-star level and then the ratio at 3-star. So for example, for 0 to 11 months, our model assumes the same ratio at both a 2-star and a 3-star. So it's a ratio of 1 to 4. The increased costs there that are shown then result from increases in other costs associated with being a 3-star provider. But as you move down to the age 2, 3, and 4-year-olds, we have a combination of the ratios also changing. So for 2-year-olds, we go from a 1 to 8 ratio to a 1 to 6 ratio. And then for 3 and 4-year-olds, the ratio goes down to 1 to 10 at the 3-star level. So these increased costs here represent both a variety of resources supporting other dimensions of quality as well as the change in the ratios, assuming smaller ratios. Another thing you might note here, as we see this range of costs going from about $16,700 on down to about $9,300 for the 3-star providers, is that we have the same cost estimate for the 12 to 23-month-year-olds and the 2-year-olds, as well as the same cost estimate for the 3s and 4s. And that's because we have the same ratio assumption. So because all assumptions about costs are the same at this 3-star level across age groups, when the ratio is the same as we move from one age group to another, the model-based estimates show the same cost. Go ahead to the next slide. Another factor that we see that's an important as a cost driver is what we refer to as underenrollment. And when we refer to underenrollment, we ask providers not only what they were licensed, their license capacity, but we ask them about their desired capacity. So in many cases, providers have a certain number of classrooms and staff those classrooms with the desired enrollment given ratios that may be less than what they're legally and their license would allow them to serve. So by under-enrollment, we are referring to providers who have fewer children than what their desired enrollment would be. So that might mean, for example, a classroom for a 4-year-old, they may be consistent with licensing standards, desiring to enroll 15 children in the classroom, but their enrollment is actually 13 or 12. And so go ahead to the next chart. What we assumed is under-enrollment meant anywhere from 1 to 2 children below their desired capacity, their desired enrollment. So it's about a 10% enrollment, under-enrollment factor. And we assume that both for centers and family child care homes. So you're seeing now a presentation of results across rows with centers differentiated by the age group in a classroom and between large and family child care homes. And what you see in the first column is a baseline estimate, and this is for a 2-star provider, both 2-star centers, 2-star family child care homes. And then our estimate if that provider was under-enrolled. And by under-enrollment in these cases, because it's just a few children, 1 or 2 children, depending upon the classroom size or the family child care home size, it's not enough to close a classroom. So effectively, you have to staff a classroom as if you had full enrollment. So these represent sort of a kind of efficiency loss in not being able to have enrollment up to the desired capacity. And you can see that the effect, depending upon the age group and centers and family child care homes, is anywhere from an increase in cost because of under-enrollment of about 8% to as high as about 14% because of this loss of enrollment. And I think this is important not only for our work as we were doing this in the pre-COVID world, but this is also indicative of what many providers are likely facing now in the context of a pandemic, where they may be operating but not operating with enrollment up to their desired level, and still having to have the same number of classrooms and staffing, but those classrooms have fewer children enrolled. And that may be both because families are not returning and in those programs before because their circumstances have changed, or they aren't comfortable with care arrangements in the current environment. And it may also be a function of changing capacity that providers are required to follow because of any COVID related requirements. So I think this recognition that under-enrollment can be an important driver upward of costs is something that is relevant both in the pre-pandemic world as well as the world that we're currently facing. Go ahead with the next slide. We also find, so I've mentioned at several points, looking at providers of different size. We refer to this as economies of scale. You might expect that as providers get larger, particularly with their fixed costs or their administrative costs, those can be spread over a larger number of children enrolled. In part, you can look at the difference between small family child care homes and large family child care homes as a type of scaling up, since we can go from 7 children being served in the smaller family child care homes on up to 12 in the larger ones. So those differences in cost there is one way to think about economies of scale. But we also looked in our model at what if we were to double the size of the center that we assumed. We allowed for some additional administrative costs because a larger center might require, for example, more supports around the administrative aspects. But what we found in general is that there were somewhat lower costs per child as providers got larger, but partly based upon the assumptions that we made, those savings because of a larger scale are somewhat modest. And so it suggests that there are differences by size, but it's not as large of a cost driver as some of the other factors that we've been looking at. Go ahead with the next chart. The last point here from our cost findings is that the cost recovery, given the subsidy reimbursement rates, also would vary. So again, what we did was we looked at our model-based assumptions and the cost per child, and then based upon what rating tier a provider was in, or in the case of centers, the ages of children served, we mapped on what the child care subsidy reimbursement rate would be for full-time care in that setting and age group. And turning to the next chart, we can illustrate what we found in terms of the percentage of the provider's estimated costs based upon our model assumptions that would be reimbursed if the child care subsidy were the only source of reimbursement. So to read this chart, across the columns are the different age groups of children in a center-based setting. So starting with the youngest age group, as we've been seeing, on up to the 4-year-olds. And the rows represent results for providers in the 4 quality rating tiers. 1 star is the 2 purple rows, the 2 blue rows are 1 star plus, then you see 2 star and 3 star. And for each rating tier, we looked at an assumption of 100% attendance. In essence, you would be receiving the full reimbursement rate. And we also allowed for the possibilities that centers might have, just like under enrollment, have attendance below full attendance. So we, in the paper, in the report, actually look at a 90% attendance rate. But here, just to give you another extreme, we looked at 80% attendance, which is not uncommon or not unheard of in some center-based settings. So what each of these cells is reporting the percentage of costs that would be recovered just given the child care subsidy reimbursement rate alone. So as an example, for an infant birth to 11 months in a 1-star center with 100% attendance, the full reimbursement rate, about 50% of the estimated cost to a center in that setting with our other assumptions would be covered. And as you look on down across the provider rating tiers in that infant column, it tends to have the lowest cost recovery rate because the costs are so high for infants, and the relative reimbursement rates for infants does not necessarily reflect that kind of cost difference. As you look across the columns to the older age groups, you do see examples that come closer to full reimbursement, such as a one-star provider with 100% attendance for a 4-year-old. Based upon our model assumptions, you would get to 99% of the cost, so effectively covering costs. But if enrollment was 80%, you would be recovering about 80% of costs. So again, you see a similar pattern where cost recovery seems to do better as you move up to older age groups. You also might notice that 2-star providers tend to do a little bit better in each of the age groups and under each of the attendance assumptions. And that reflects some adjustments that were made in recent years to try to bring the 2-star providers up to a higher reimbursement rate. So that has tended to benefit their cost recovery, again, based on our model assumptions, relative to the providers in the other rating tiers. So let me now move to some of the implications and the recommendations, and we're coming close to the formal part of the presentation. So starting with implications, first in terms of providers and their financials, we know that from these findings that licensing and QRIS requirements are important drivers of cost, but because we saw providers making a variety of choices around other program structures, there are aspects of provider choice that matter too. So some providers may be choosing to use resources that push them toward a higher cost per child, and others may be using resources more conservatively so that they're on the lower end of the cost per child scale, all while meeting, licensing or QRIS requirements depending upon where they are in reaching for the stars. And so what that means is it's very hard for us, for example, to have a cost model that's going to generalize to every provider because of this provider choice that is in part determining their cost structure. We could see from our estimates that operating with less than full enrollment, so the under-enrollment I referred to, but also high rates of absenteeism have a similar effect, is costly for providers. And this may, in some cases, be a provider choice, but often it's a function of being able to recruit families to fill all the seats that you have, all the slots that are available, and also whether or not families are able to have their child enrolled and attend, particularly those who are receiving subsidies, since it affects the reimbursement. Licensed providers may benefit, in particular, those providers that were the focus of our study, from technical assistance around financial literacy and business management. And this is not necessarily an issue across the board, but based upon the providers we interviewed, we definitely think that there's an opportunity to bring greater financial capacity to the sort of the business side of running either child care centers or family child care homes. And that we also, to the extent we saw gaps in provider participation and take up either the child care subsidy program or in the USDA CACFP, that might be something to examine more closely to understand what are the factors that are precluding particularly family child care homes, smaller homes, from participating in the subsidy program, and for those providers, whether centers or family child care homes, who don't take up the USDA subsidies, because that is a potential additional source of reimbursement for provider costs. Go ahead to the next chart. We also have implications about the subsidy reimbursement rates and the use of cost information. So we think that from what we're seeing and based upon the model estimates, that the subsidy reimbursement schedule may not fully align in its present structure with how provider costs might be expected to vary based upon the child age group and reaching for the STARS tiers. And this is particularly relevant for centers. So let me illustrate what I mean by that. So if we turn to the next slide, showing the 5 age groups across the rows, in the columns, we're showing the teacher-child ratio separately for 1-star through 2-star provider based on licensing. And then the 3-star is based upon NAEYC assumptions about the ratios. And one of the things I noted earlier is that we estimated that the cost would be effectively the same for 12 to 23-month-year-olds and 2-year-olds, simply based on the ratios being the same for 3-star providers if they follow NAEYC standards, and the same for 3 and 4 group together. Yet the ratios do vary for the licensing across all 5 age groups. But one thing you notice when you look at the daily reimbursement rates, which are shown in the last 2 columns for 2-star and 3-star, that those rates don't change between the 2 and the 3-year-olds, although that crosses over for 3-star providers where there's a ratio change. There's also a ratio change in the 1-star to 2-star providers. So the reimbursement is held constant, but because the ratios are changing, we would expect costs to vary in a way that's not reflected in that reimbursement structure. The reimbursement structure otherwise does have higher reimbursement for the youngest children, gradually decreasing to the rate for the 4-year-olds. But the fact that that rate is held constant across 2 age groups where ratios do change suggests that those constant reimbursement rates may not be able to fully capture the change in provider costs across the 2 and 3-year-olds. Go ahead to the next chart. Ultimately, a policy consideration for setting subsidy rates is which sources of cost variation should be recognized in those reimbursement rates that I showed you a moment ago. And so in Oklahoma, for example, right now there's a unified rate across the state. Some states allow the reimbursement rates to vary across different parts of the state based upon cost variation. It might be a regional differences, it might be county differences, it might be a zone-based approach. So is that an important factor to recognize? Other factors that one might recognize would be, for example, whether or not a provider is paying for the cost of their space, or is that cost subsidized? That has an important difference, not one that I talked about through this discussion, but is also one we recognize in the report. And then ultimately, what we hope this study demonstrates is that using the kind of cost information we've incorporated, whether it's from cost data collection or cost modeling, can help inform rate setting. And so we're not necessarily suggesting that the estimates that our report are the exact estimates that should be used going forward, because there may be a reason to adjust some of the assumptions that we've made, but it does illustrate how this kind of information can be used to look against the current reimbursement rate structure and that schedule of reimbursements. So go ahead to the next slide, which is our final recommendations. So ultimately, we think there's an opportunity for Oklahoma, which is true for other states who are also starting to look at the role that cost information can play, to bring that information, either cost modeling or cost data collected from providers, to look at the child care subsidy program reimbursement schedule. And this is something that the federal government is now recommending as part of CCDF, that this kind of alternative methodology would be brought into helping to set reimbursement rates in a way that is consistent with the kinds of costs that providers face and how costs vary with quality. Secondly, we think that there may be an opportunity to consider options for tying higher subsidy reimbursement as providers move up the quality rating tiers to specific spending in resources that matter for quality. So as I mentioned, one of the things we assumed is that as providers move up the rating tiers and there are higher standards, for example, with respect to the learning environment, that means providers are going to be spending more resources. They're going to be increasing the compensation to their staff because of higher expectations there. But that's not necessarily part of the quality rating system as it currently stands in Oklahoma. So providers may be able to meet the higher quality standards, but not necessarily have that reflected in actual higher costs. And that some of that may be possible to do. There may be ways to better use staff time that doesn't necessarily increase the cost, but gets you to higher quality. So that may be possible, but there may be other ways in which there are opportunities to see that providers in moving up the quality tiers, for example, might be reimbursing their staff consistent with higher quality. We also suggest an opportunity to review participation in the CACFP program on the part of the CCE providers in the state, and also to consider ways in which home-based providers may have access to additional supports to improve their financial record keeping and consistency in favorable business practices. That may be something that centers would benefit from as well. We can turn to the last slide. Here, I've just indicated that the report is currently available in a pre-release version. If you go to www.ran.org, and then the rest of that URL is shown there. In the first instance, you'll find the pre-release version, and the final version will be posted on that second link. And I know we'll work with OPSR to make sure those of you who are interested can get access to those documents, both once posted now. The final version, the main difference with the final version will be a fancier cover, and it'll have edits from the professional editorial team, whereas the version that's posted now has gone through all of the quality review process, but just has not been gone through the final editing. So we appreciate your interest in this work and look forward to the discussion.
Thank you, Lynn.
And let's just, yeah, there we go. There's the chart.
Thank you. So at this time, I think let's turn it over to Stephanie to see if there's any questions from the chat. I think she answered a few, but Stephanie, let's go ahead and let you take the floor and see if there's anything you'd like to have Lynn discuss further.
Thank you, Deborah. Thank you, Lynn. Lynn, there was a question. I'm not sure if it was slide 30 or 31, but it was around about there. And someone asked for some clarification about how the effect of under-enrollment was calculated, and in particular, the metric you used to determine what under-enrollment was.
Okay. So it actually is slide 31. So Courtney, I don't know if we can go backwards to that slide just so people are seeing it in real time. It's 31, which is, yeah, right there. So the way we thought about this was take, for example, under the licensing standards for a 4-year-old, you could enroll up to 15 children per staff member. So if I had that right, so that could be up to 30 children in a group. Or if you went down one level to 3-year-olds, ratio of 1 to 12, so it could be if that's your desired enrollment. So what we did instead was we said a provider still has to pay for the cost of that classroom. There would be somewhat fewer costs because if you only had your desired enrollment was 12 children in a classroom, but you only had 10, or you only had 11, there wouldn't be the food costs for that child, but you're still having to prepare all the meals. So on the margin, the savings of food for one fewer child is not that great. So you still have to staff the classroom. We would assume that you still have all the same administrative staff. So essentially what the calculation amounts to is that the center's overall cost structure, if you think about their spending during the year, would be very similar, somewhat reduced because of the some of the resources that the children who aren't there are not using. But then we would divide by the new enrollment number. So instead of being able to divide in a classroom that could be up to 24 by 24, we now divide by 23 or 22. And so because the numerator is not changing very much, but the denominator is changing, then we see that increase in cost and in these range of 8% to 14%. And we detail in the document typically, so for a classroom that was infants where it's a ratio of 1 to 4 and a group size up to 8, if that was the desired enrollment, we looked at it dropping to 7, which is about a 10% drop. in the case of the older ages where you're talking about, say, 24 children in a group, the 10% amounted to about we assume 2 fewer children relative to desired enrollment. So it's either 1, 2, I think in some cases there might have been 3 children we assumed were not enrolled, where that number got bigger as you went to the older age groups. In the family child care homes, it was generally 1 fewer children, either in a large family child care home or a small family child care home.
And Lynn, I know in our report you looked at under-enrollment in terms of how under-enrollment by percentage of desired enrollment. You know, if they 10% under-enroll,
yeah, so
under-enroll. What are we looking at here on this slide?
Okay, so yeah, that's a good, just to be clear about the terminology we're using. So there's 2 types, if you will, of being under capacity. One is in what we refer to as enrollment. So think about that as, you know, the children that you have registered and the family is, you know, the family is there coming to, the child is coming to the program. And so when we talk about under enrollment, it means you don't have that child enrolled in the program. So if your total center, typically, you know, your desired enrollment is 100 children in the center, and now you're down to 98 or 95, that's under enrollment. We also looked at the effect of, when we're talking about the subsidy reimbursement, so less so on the cost side, but now on the reimbursement side, what would happen in accounting for less than 100% attendance. And so the reason that's important is because you are reimbursed for a child who is enrolled only on the days that they are there actually attending. And so if a child has perfect attendance, they're there 100% of the time over the course of the year, you would get the full reimbursement. But if over the course of the year they are absent 10% of the time in such a way that there's 10% of that full reimbursement for the year that you're not receiving, that's what we look at. And that would be now on slide like 34. So where we're assuming now in effect full enrollment, but the attendance day by day among those who are enrolled may be either at a perfect attendance, 100%, or something less. And we actually have 3 different assumptions in the report: 100%, 90%, and 80%. Typically, as people think about attendance, 90% or lower attendance is considered chronic absenteeism in the lingo, particularly around K-12 education. And we know under attendance or absenteeism is an issue in the early childhood context as well. And this becomes important around subsidy reimbursement. And most states do what Oklahoma does, which is tie reimbursement to attendance. But that may mean that a provider, again, even though the child's not there on a given day, you still have to staff a classroom as if that child was there. You probably have planned meals, which means you're still preparing meals as if that child is there. All the other resources that it takes to operate that program, all those costs are still there, but you may have these children who are absent, which means you aren't getting reimbursed for those costs that you face. And so this is a consideration around how states structure their subsidy rates, and, you know, whether there are ways to support families in getting to more complete attendance, or recognizing on the reimbursement side that some absenteeism, you know, may be considered more normal, and so that reimbursement rates would be structured accordingly. So just differentiating between, there are really 2 similar kinds of inefficiencies, if you will. Either you don't have a child enrolled, so you're under enrolled, or you might be at full enrollment, but because children on a day-by-day basis are not there 100% of the time, you have that absenteeism or less than perfect attendance.
Lynn, there was another question related to the model, and that was, what were the assumptions for wages for teachers? So does it assume the actual rate, or does it assume a better wage, and is that information included in the report?
Great, yes, it is. So what we did was, again, with our providers, we did ask about the actual salaries or salaries for a group, like all the teachers in a room. For our model, we relied on data that's collected and reported by the Bureau of Labor Statistics. It's referred to as occupational wage data. And so, for example, a child care worker is an occupation that the Bureau of Labor Statistics collects data for every state, also within states, the metropolitan areas. And so we use the information from the Bureau of Labor Statistics on the wages paid in different categories of jobs. So child care workers, preschool teachers, assistant teachers, directors, and so on. And that's all detailed in the report. But we used information not only about the typical teacher, which is referred to as the median, the person in the middle of the wage distribution, but we used information about the lower end of that wage distribution and the higher end of the wage distribution. And so particularly for the 1-star and 1-star plus providers, we were using estimates of wages from the lower end of that distribution reported for Oklahoma as a whole. And at the 3- and 4-star levels, we were using estimates of that distribution from the higher end. And you can think of that as an increase in compensation possibly for 2 reasons. One is that at higher quality ratings, the programs are employing teachers that have higher credentials or even degrees, and recognizing that in their compensation. Or it may be that they're more experienced, or they're paying higher wages in order to retain them and not have high rates of turnover. And so it's a way of allowing for some gradation in the salaries as you move across the rating tiers that's consistent with the overall distributions of salaries in Oklahoma. And again, I don't have the numbers right in front of me, but in the report, it's in the appendices, you'll see what those distributions look like. For child care workers, it still is very low compensation. And for example, if you were to look at these estimates in the report, Deborah mentioned at the beginning that I was part of the National Academy study that looked at financing early care and education system for the U.S. with a well-compensated, effective workforce. There, we actually assumed compensation parity, for example, that center-based ECE teachers outside of a public school system would be compensated at a level consistent with those public school providers. So, so I would say that even our assumptions here with the cost estimates are still pretty modest salary estimates, but they are consistent with what salaries are being paid across Oklahoma today.
Thank you, Lynn. And we have with us Representative Carol Bush, State Representative Carol Bush, and her hand was raised earlier. And Representative Bush, I believe you're able to speak if you'd like to address Lynn and with your question.
Okay, can you all hear me?
Yeah.
Oh, okay.
Yes.
Sorry. I'm at the Capitol and I haven't done a Zoom on this computer, so I didn't mean to have my hand up, so I apologize. But really good. I just want to say this is just really good data, very very informative. And I actually just typed this in. I think you said where we could get a copy of this when you were finished, and I missed that.
Yeah, so I was referring to the report, but I know OPSR is going to feature both the recording and we'll have a version of the slides also available. So, and I will mention as well that the report does have an executive summary so that those who don't want to get into all of the nitty-gritty detail will see the basic content that really parallels what I've presented today in that summary. So it's at the front of the document.
Thank you.
Yes, and we can also, I think we have this in our plans, to send out links to the participants today as well. So thank you.
Great. Thank you, Deborah, and thank you for joining us, Representative Bush. Lynn, there's another question that's sort of a broader question, and it sort of harkens back to some of your other experiences. Can you talk a little bit about how other states are doing cost studies? I'm not sure if they mean methodology, how they're funding them, or both. And just also some of the challenges that are involved in getting good cost figures for this type of work.
Yeah, that's a great question. So I mentioned that CCDF in the reauthorization, I think 2014, introduced language around establishing reimbursement rates that references the use of alternative methodologies, including incorporating information about provider costs, whether that might be direct data collection as well as using a cost model. And there are models publicly available, like the provider cost of quality calculator that were developed specifically for this purpose, and that calculator would produce very similar estimates with the same assumptions as what we've produced here. So what I'm seeing from the states I'm aware of is that states are starting to kind of like dabble their toes in the waters of how to incorporate this kind of information into rate setting. And there's a nice, I was part of the group that wrote kind of some guidance around this that ACF published a couple of years ago, and I can make sure, Deborah, that you have access to it and can point people to it, that talked about how you might go about doing this. And certainly the data collection of cost data from providers is very time consuming, both for the providers involved in gathering this information and in the team going around and trying to assemble it in a consistent way. And so that's been a barrier to bringing in cost information. It's much easier for providers to tell you about their prices. And so that's why we do market rate surveys, because those prices, may be posted somewhere or well established, and it's just a few numbers. But really understanding a provider's, the resources that they use and breaking it out by child age. So one of the things that we did in our data collection was we asked about costs specific to each classroom so that we would know if this was an infant classroom, here's what it's costing to serve those children. If this is a classroom for 4-year-olds, here's what it's costing. And then we added in the overall center level cost. So it's a combination of classroom specific costs for a child age group and the overall center cost. So I'm aware of some states that are starting to do this. Some states have gotten more organized with their providers to help them have maybe even a common financial reporting system that providers are using that makes it easier for providers to report in a consistent way, what their expenditures look like in a given year. So that may be a direction that some are going. But I would say more states than beyond those that are collecting cost data are starting to think about using cost models. And so that is starting to be, and then the provider cost of quality calculator was developed specifically, for that kind of purpose. So I'd say we're going to see more of this, providers either participating in cost studies or the use of cost modeling as a way to, not that it's the only information that you want in setting rates, there may be other considerations that go into rate setting, but it's like another piece of information that is useful for guiding both the level of rates and also the structure. Where do you see changes in the rates as you move across child age groups or across rating tiers?
Stephanie, were there any other questions?
Hi, there's a couple other questions that sort of are related to the policy implications of this. You were discussing underenrollment. Someone suggested that perhaps this information is an argument for moving the reimbursement from being attendance-based to being enrollment-based. And I'm just wondering if you might want to take a few minutes to discuss just how stakeholders and decision makers might want to think about or how they could possibly use this information to inform decision making around these types of policy decisions.
Yeah. So I do think that's definitely one of the kind of policy decisions that the states make is whether or not reimbursements are going to be tied to actual attendance or, having a child enrolled. And I think one first step is to understand what your attendance patterns look like, to get a handle on the extent of absenteeism for children, in the child care subsidy program, and anything you can do to understand the reasons for that absenteeism. What are the factors that families face that affect their ability to have their child, every day at a child care center, family child care home where they're enrolled and their attendance is being subsidized? Because, many families with lower income who are receiving subsidies, their lives are complicated. There may be transportation issues. There may be issues, with combining getting a younger child to childcare and older children to school, a variety of factors. And of course, we know, that there's some absenteeism because children are sick, or, there are factors that prevent being, the sort of excusable reasons a child needs to have a doctor's visit or whatever. So I think it's, understanding what factors are behind, the extent of underenrollment, what factors are behind it, and then what are the implications for providers? Because I think, ultimately, to the extent that these are factors that are out of the hands of providers, that would argue toward reimbursement based on enrollment rather than attendance. On the other hand, ideally, we'd like families to be participating fully and the children to be benefiting from the, the early learning and care that they're participating in. So how can you help address those factors that are behind the attendance issues? And is that something that the providers themselves can help with? Or are there other kinds of supports that families might need to, address the factors that are affecting their child's attendance? So I think it's definitely an issue worth considering. It's not as well documented. I've tried to document this across the states and there's policies. It's not as well documented to know how much variation there is across states, but I do believe that reimbursement tied to attendance is the norm across states, but that some do base it on enrollment.
Great, thank you, Lynn. And someone noted while you were speaking that the Cherokee Nation subsidy they moved to paying based on enrollment instead of attendance during the pandemic.
Yeah, and that's, I think, there's examples where because of the pandemic, we're sort of changing some of these rules, and I think it's a good opportunity to see what a difference it makes. And this pandemic has been a reason to modify. I know a number of states have done that kind of on an emergency basis, but it's an opportunity to look and see, well, what has that meant for providers and their ability to really deliver high quality care? What has it meant for the families to know that they're not going to be dunned in some way for not being there, and to try to understand that issue better and what it might mean going forward. Is that a policy to consider changing?
Great. And someone mentioned that they think some other tribes had been paying based on enrollment historically. I don't have any other questions posted, so I addressed everything that people raised, but we have been giving a lot of thank yous, so appreciate that. And Tori from OPSR just posted the link onto the chat box that will have will enable people to access the recording of the webinar and the report.
Okay, thank you. If we have no further questions, I will close out this incredibly informative presentation. I will mention, and we did have a comment in the chat box about Secretary Brown had referenced a previous opportunity to go through this report. This is probably I don't know how many times I've had a chance to look at the report, and I gained something valuable out of it each time. About 3 weeks ago, Lynn presented the report to the OPSR board and some of the stakeholders who worked really closely with us with the OK Futures grant. And that was for the purpose of ensuring that there were any questions about how well the information reflects what we know about Oklahoma, and making sure that it resonated with the state and our partners. We have not really had a chance to process as a group across OPSR what we might want to do or propose with these recommendations. I will say that OPSR is in the process of submitting some recommendations during the pandemic, and how we believe emergency relief dollars that either are available potentially now or could potentially be available in the future to help support the stabilization and certainly thinking about stabilization of childcare as such a critical component. So this is really our first official release, and we'll now move this conversation into a broader public discussion of what do we want to do with these findings. As I said, all good research leads to new questions, and I think this widely contributed to our knowledge in the state on the cost of care and the quality rating as reported by a representative sample of child care providers in Oklahoma. So what we do with this next is yet to be seen. We appreciate those of you that provided questions and have thoughts and reflections on this. I definitely want to extend my deep appreciation to both Lynn and Stephanie for their work on this report. As I said, it was a quick time frame, and the funding that we allocated for this probably wasn't, it was a drop in the bucket to what a more extensive cost study could have got us, and probably didn't near meet some of the needs that they probably had financially. They were great about consulting with OPSR, our partners, and with child care services at DHS to ensure that we were accurately reflecting what we know about care in Oklahoma. So thank you so much for your work. I also want to thank, we have several state legislators who participated in the call today. We heard from Representative Bush. I noticed a few others in the participant list. Thank you so much for being with us today. We hope this information provided you with some valuable information as you get ready to go into what's going to be a pretty tough legislative session in the new year, and there'll be a lot of difficult financial decisions we anticipate. We know that higher quality leads to improved outcomes for kids. Starting early is so important. We know that all of you appreciate the significant contribution that childcare provides to both our state's economy and also in providing family support services to mitigate child maltreatment. A lot of blogs and information. We've always talked about the connection of that, but that's another critical area in our state that we want to see improved outcomes, and childcare can definitely play a strong role in that. Thank you to all of you who participated today. We hope this information provides new insights into your work. Courtney's going to put up a poll, and I'm going to continue to give a few thanks while you complete the poll about the evaluation of the session today. I do want to mention that we're grateful for the support of the OPSR board members and the OPSR Foundation directors. Without their support, we could not do this work. And finally, I really want to express a big thank you to all of the childcare providers in our state, with a particular recognition to those that participated in this study. We recognize this was extra work for you on top of your already busy days, and we appreciate the time you spent in gathering the information so that we could have this body of information to contribute to our knowledge in the state. It's not said often enough, but you are our heroes every day, and especially now as you've been there for our kids, and so that their families can work during the pandemic. We appreciate you as much as ever, and we're committed to finding ways to ensure that this important part of the early childhood system is stabilized. Again, if you'll take a look at the poll, select the option that best represents your evaluation of the session and your satisfaction of meeting your expectations. In closing, once again, I want to acknowledge that this presentation was supported by the Preschool Development Grant, Birth to 5 initial grant that was awarded by the U.S. Departments of Health and Human Services and Education, administered by the Administration for Children and Families, Office of Child Care, to the state of Oklahoma. The grant was administered by the Oklahoma Partnership for School Readiness and informed by over 400 state, community, and parent partners across the state. Again, thank you for your participation. We intend to continue to partner with you to inform best practices, adequate funding, and equitable access to early childhood care and education services. And with that, we will close. Thank you all for being here and have a great day.